we're joined by Ms Niyati Lobo, who's an ST6 in urology in the KSS Deanery. So before we get started, I want to just give you a couple of technical points. So if you do have any tech issues, please feel free to use the chat function below, either if you're on Zoom or YouTube. We are going to be covering a couple of points that we're going to ask MCQs about. I'm going to post the link in both chat functions, but we'll also have some QR codes on our slides for you to use to access the Mentimeter. So I think that's all. We also have a Q&A at the end of our webinar. So if you have any questions, please feel free to, again, enter any questions you have in our chat function, and I can ask Niyati at the end of it. So shall we start? All right, Niyati.
Okay, so hi everyone. So as Ratija said, I'm Niyati, I'm an ST6, I work at Brighton at the moment, and we're going to cover all the sort of things you need to know to sort your ward patients out, your on-call patients, and hopefully you'll feel really confident to do that by the end of this talk. So just a few introductory slides. So at the beginning of the presentation, we're going to give you a couple of, well, more than a couple, 5 questions just to whet your appetite and assess your own knowledge about urology, and you can participate using the QR code on the slides themselves. There's a disclaimer there for you to read. The aims of the webinar are really just to get you feeling more confident and empowered to manage urology patients or just general patients with urological issues on whatever ward you work on. So what we're going to start off with is catheters, and that might sound really boring, but actually no matter what specialty you end up doing, you will have to deal with a catheter at some point. And I'm going to give you all the tips and tricks to manage your patients, manage common problems, so you don't feel worried or anxious about having a go at trying to catheterize someone. We'll then move on to urinary retention, and then we'll do the slightly more exciting stuff, so looking at the difference between paraphimosis and phimosis, renal colic, and then the acute scrotum. So these are your MCQs coming up, and as Ratija said, that is your QR code, so you can participate via Mentimeter using this code. So if everyone's ready, this is the first question. So the chance of passing a less than 5 millimeter distal ureteric stone is approximately, I'll give you a couple of seconds to answer. Okay, moving to the next question. Chronic urinary retention is associated with which of these features? Next question. Post-obstructive diuresis is defined as which of these? Next question. Patients with post-obstructive diuresis should have fluid replacement at what percentage of the previous hour's urine output? And finally, what is this? Is it A, penile cancer, B, balanitis, C, phimosis, or D, paraphimosis? Okay, so by the end of this, you should be able to answer all of those questions with no problems. So first of all, catheters. So I'm sure as soon as you hear the word catheter, this is what comes to mind. And I don't blame you, but why should you care? Well, it's really all about patience. If you want to look after your patients, you care about them, then you'll want to get good at catheters, because you can do a lot of good with a catheter, patient in retention, patient with hematuria. You really have the ability to fix them just by inserting a catheter in most cases. But it's not just about patients. Spare a thought for your friendly urology registrar who gets a call at 3 o'clock in the morning about catheters. So hopefully if you feel able to insert catheters and know all the troubleshooting, you will feel able to do this yourself and won't be waking up grumpy registrars at 3 o'clock in the morning. So these are some of the common problems that we get calls about. The first problem, I can't get a catheter in. Now, there are three main reasons for that problem. The first is benign prostatic enlargement. The next is a stricture. And then finally, there's poor technique. And we'll cover all of these in detail. So firstly, benign prostatic enlargement. So as men get older, their prostates get bigger, and that is just a consequence of aging. So this is the view that you would see, that I would see, for example, if I was doing a flexible cystoscopy. So that's where we place a catheter, a cystoscope, which is a camera, down a patient's water pipe, and we move through their urethra, past their prostate and into their bladder. And that's a diagnostic investigation we do to look inside people's bladders. Now, on the left-hand side, you can see a normal view, a normal prostate. You can see the prostatic lobes on each side, and then the big black hole is the bladder, and that is where your catheter goes through. And you can appreciate, I think, that there's a nice big hole there which you can get your catheter through easily. Now, on the right-hand side, this is what an enlarged prostate looks like. So this is really what you're going to find in men sort of over the age of 50, 60. And I think, again, you can appreciate here that the prostatic lobes have become occlusive. So they're what we call kissing. So they're in contact with each other, and you can't see the opening into the bladder there. So when you have a male patient, elderly male patient with an enlarged prostate, and you can't get a catheter in, this is probably why. You've got an obstructive prostate, which the catheter is abutting as it's trying to get into the bladder. And we have ways around this. So the first thing to do is suspect that you might be dealing with an obstructive prostate. So if you've got a gentleman over the age of 50, if they're telling you when you talk to them, yep, I'm up at night all the time passing urine, I have a poor flow, I dribble, I stop and start when I pee, I feel like I don't empty my bladder when I pee, then think, okay, this is someone that probably has an enlarged prostate. And the trick for this is to use a Coude or Tiemann tip catheter, and this will get you out of trouble almost all of the time. Now, you're going to ask me, what is a Coude or Tiemann tip catheter? And this is what it is. So it is an angled catheter, so a catheter where the tip is angled, and that angulation just gets around the curve of the prostate. And you can see the difference with that compared to a straight tip catheter or normal urethral catheter. And the common question we get asked is, which way do you insert the catheter? And you want to insert it with the tip pointing upwards, because that's it's going to curve around the prostate. Now, where do you get these catheters? You'll ask your ward nurses and they'll have no clue, they'll never have heard of them before. So there are three places, and all hospitals will have these catheters. If they're not called Coude tips, they're called Tiemann tips. So you can either you'll definitely find them on a urology ward, but you'll also find them in A&E and in theatres. And if people in A&E or theatres tell you that they've never heard of them or don't have them, that's almost certainly not right, because all urology theatres have them and A&E tend to keep a few as well. So so you put them in with the tip angulated upwards, facing upwards, and this diagram just shows you how the tip just curves around the bend of the prostate, and that's why they're so nice to use in men with big prostates. And those are the patients that often they come to us and they've had 3, 4, 5 attempts at a catheter, maybe an A&E, and then we come along with our Cudo tip catheters and get them in first time round and look very impressive, but it's really just the kit. So you've got to have the right kit for the right patient. So another reason why you might fail to get a catheter in is a stricture. So a stricture is scar tissue formation in your urethra. And I think you can appreciate in these pictures that there is a caliber change. So you're going from a lumen which is nice and wide open to a really narrow, almost pinhole lumen in the right-hand picture. Now, when do you suspect strictures? Because you're not going to see these. You've got to have a threshold for thinking that your patient might have one. And this isn't necessarily strictly true for everyone, but if you've got a young patient, so a young 20, 30-year-old patient, and they've said, I have had a weak flow for as long as I remember, oh, doctor, it's a running joke in my family that I take forever to empty my bladder compared to my brothers or my dad. Just think, okay, maybe this is someone that's has a congenital stricture. Other causes for strictures are trauma, so catheterizations that haven't been done correctly. Sometimes we cause them with our instruments, putting cystoscopes and things down people. You can get them in trauma, so following a pelvic fracture. But if you've got a young person that's giving you this classic history and you suspect that this person has a stricture, obviously have a go yourself first, have a gentle go. But if you are getting resistance, and the resistance is usually higher than resistance you get with the BPH patients, just call us, call a urologist, because you don't want to have multiple goes at putting catheters in, because you're just going to traumatize the urethra and you're going to cause a false passage. And what we do is we dilate these strictures, but we have all the kit to do it. So my advice is, if you have someone you think may have a stricture and you've had one gentle attempt at putting one in, give us a call and we'll come and have a look at them. The third reason is poor technique, and really practice makes perfect. We get a lot of phone calls saying, I don't want, this patient needs a catheter. Well, have you tried? No, I'm not happy to put one in. And I think that really you're only going to be happy if you practice and know yourself that you can sort of get out of trouble, and you can do it. So I would say that with the right kit, have a go. And then if you're still stuck, call your friendly urologist and we'll be very happy to come along. So this is the second problem. I can't find the urethral meatus. So urethral meatus, the meatus is just the hole at the end of your water pipe that you pee out of. And there are two reasons for that. So one is a phimosis, and that is the most common reason, I would say, from phone calls that we get. And then a much less common reason, but sometimes you do see now and again, is a hypospadias. So we're just going to talk about phimosis for a second. So phimosis just means a tight foreskin. You've got two examples here. So the picture on the left, you can see that there is quite a tight foreskin. You can't retract the foreskin beyond the glans or the head of the penis, but that slit in the middle is the urethral meatus, so you can still see that. So you can definitely still get a catheter there because you can see the location of the meatus. And this is compared to the picture on the right. So that is a completely fused foreskin and you cannot see the meatus there whatsoever. So that's when you need to give us a call, because we'll come along and try and separate, unfuse that foreskin and get a catheter in like that. But that's the difference, and it's really helpful to see these pictures so you know what you're describing to the to us when you call us about this. The other reason, as I mentioned earlier, is a hypospadias. So a hypospadias is when the urethral meatus is not where you expect to see it. So instead of at the tip of the glands in the middle, you can get it all the way down the shaft, all the way to the pinoscrotal perineum. But those are really, really rare. But if you really can't see a meatus and you're sure that the patient doesn't have a phimosis, then it's worth looking down the ventral shaft to see whether or not there's another opening. But again, this is a situation where if you're really struggling, just call your urology reg and they'll come and have a look for one. Okay, this is a phone call that I get all the time. The catheter is bypassing. So what does bypassing mean? So bypassing just means that instead of urine going through the catheter and into the catheter bag, you're getting some urine passing along the catheter. So it's coming around the catheter. And people get really upset and sort of worried and anxious about this. So a little bypassing is not uncommon and it's not a problem. But if you've got large amounts of bypassing, what you have to think about is why is that happening? And the reason that can happen is the urine is just taking the path of least resistance. So if you've got debris in the bladder, stones in the bladder, clot in the bladder, then you're going to have urine taking the path of least resistance and it's going to come out around the catheter. And the way to fix that is by performing a bladder washout, which I will talk you through shortly. The second reason is you can have bladder spasms. So the detrusor muscle in your bladder contracts. Often patients feel the they sometimes can feel the catheter balloon, but what they complain of is having bladder spasms as a result of having the balloon. So the balloon is a foreign body in the bladder and it sends signals to the brain, and the bladder tries to expel that catheter balloon, and that's what causes the bladder spasms. And with those bladder spasms, you can leak some urine around the catheter.
Sorry, Niyati, can I interrupt for a second?
Sure.
We have a question from an attendee asking what actually is a bypassing catheter?
So a bypassing catheter, so it's rather, I suppose the terminology is not right. It's urine that is bypassing. So instead of urine, so urine should go from the bladder through the catheter tubing into the catheter bag, but when urine bypasses the catheter, it goes around the catheter. So what nurses will tell you is that they've got a catheter, but they're still leaking urine. They're still wetting their pads, or their underwear is getting wet because urine is coming through the meatus around the catheter. Is that clear? Have I explained that okay? Yeah. So yeah, as I say, bladder spasms is another reason, and what I do in this situation is give the patient an anticholinergic, so something to relax the muscles of the bladder, and that's solifenacin 5 milligrams once a day, which you can up titrate to 10 milligrams once a day if the 5 milligrams doesn't work. Okay, another problem, the catheter is blocked. So you need to approach this in a stepwise format. So first of all, make sure your catheter is in the correct position. So you should be able to push the catheter in all the way to the hilt. If you've got a really long length of catheter lying outside the penis, that catheter is not in the correct position at all. It's slipped out. So you need to have a look at the position of the catheter, look at the hilt. That should be close to the glands, close to the penis. If you're worried that the catheter isn't in the correct position, all you do is deflate the balloon and advance the catheter and then re-inflate. So once you're happy that the catheter is in the correct position, you then perform a bladder washout, because the catheter is usually blocked because of debris or because of clot in the bladder. And the way to fix both of those problems is by washing the bladder out. So I would really recommend this video. It goes through the motions really well, but the essential steps are, when you're doing a bladder washout, you can do this through a two-way catheter and you can do this through a three-way catheter. So some people might say to you, oh no, you can only do a bladder washout through a three-way. That's not true at all. You can do a bladder washout through a two-way catheter. What you need is all the kit that you see in that screenshot. So you need a bottle of sterile water or sterile saline. You need a bladder syringe, and that is a specific type of syringe. It isn't one of the Luer lock ones. And you need a receptacle to get rid of the rubbish. That's about it. So you start off by putting in 50 mils of water or saline into the bladder. And once you've done that, you put another 50 mils in slowly, and then you aspirate that 50 mils, and you keep doing that. And by doing that, you'll get clot out, you'll get debris out, and you just keep doing that until the urine goes from bright red to a nice rosé color or clear, or all the debris is washed out. But I would definitely recommend this video. Are there any questions about bladder washout, Rituja?
Yeah, so one question is asked, can F1s prescribe solifenacin, or is it urology that must do this? This is actually relating to the last thing you were talking about.
Sure. So, yeah, as an F1, you can definitely prescribe solifenacin, absolutely. And it's not really going to do much harm at 5 milligrams. There are contraindications, so people with memory impairment, people with cardiac issues, so I think it can cause QT prolongation. But yes, you can prescribe it, absolutely. If you're worried about a contraindication, just check the BNF. Okay, so some myths about catheters that I really want to bust. So three-way catheters can only be inserted by urologists. That is categorically untrue, and I'm going to show you why in my next slide. So essentially, as you can see here, there is practically no difference between a two-way catheter and a three-way catheter. The difference is the end of the catheter and the number of ports the catheter has. So you can see that with your two-way catheter here, you've got 2 ports. You've got this for the bag and this, your balloon port here. A three-way catheter has an additional port for irrigation. So that is your irrigation port. The middle one there is where you attach your leg bag, and that is your balloon port. So you can see they look more or less exactly the same. So if you can put a two-way catheter in, you can definitely put a three-way catheter in. And you shouldn't be afraid to try. So as I say, so this is a three-way catheter, the end of one. This is the irrigation port. This is the leg bag, the catheter bag, and this is your balloon port. So when would you put in a three-way catheter? So for hematuria. So for people that have frank hematuria or they've come in clot retention, you place a three-way catheter in because you can run irrigating fluid through this port and wash out all of that blood. So bleeding in the bladder will clot. And if you form clots in your bladder, the bleeding continues and you might go into clot retention. By running irrigating fluid through the catheter, you're basically washing out all of that bleeding and stopping it from forming clots.
We've got another question, and that's asking, would F1s be expected to do the irrigation?
So it's normally your nurses that will put up the irrigation. It's not difficult to put irrigation up, but you as an F1 are ridiculously busy. You've got a million things to do, and it is actually a nursing job. So just as nurses would put up IV fluids, then nurses put up irrigating fluid. You may have some resistance asking your nurses or getting the nurses to do this on certain wards, but what I normally say is it's very simple to do. It's literally connecting a tube to the end of your irrigation port. But if your nurses have anxiety about that, then just ask them to contact the nurses on the urology ward, and then our urology nurses just on the ward are always happy to provide some sort of over the phone telephone advice. And once your nurses see how easy it is, it's not a problem.
We also have another question, and it's asking, when should you suspect a catheter is blocked rather than the patient having a low urine output?
That's a really good question, and the answer to that is usually it's fairly obvious, but if there's any doubt, you give your patient a fluid challenge, so either 250 or 500 mils of urine. The other thing you can do is do a bladder scan. So if you scan the patient's bladder and the bladder is empty, the problem is that they're dry, not that they have a blocked catheter. However, if when you bladder scan them, they've got 500 mils in their bladder, then that is a blocked catheter. So bladder scanning is really useful. If your ward doesn't have a bladder scanner, again, there is one available on a urology ward. So the ward staff just have to arrange to borrow it. Right. Another common myth, suprapubic catheters can only be changed by urologists. So suprapubic catheters are often easier to change than urethral catheters because you're literally going straight down the suprapubic tract into the bladder. You don't have to negotiate the urethra, you don't have to negotiate the prostate. With that said, the first suprapubic change has to be done in a urology department. But after that, subsequent changes can be done by anyone, really. So as long as it's not the first time the patient is having their suprapubic catheter changed, then it is fine for you to have a go. And suprapubic catheters get changed every 3 months or so. If a suprapubic catheter falls out, it's essential that it's replaced immediately. Otherwise, what happens is that the tract closes and then the patient requires another operation under anaesthetic to reinsert the suprapubic catheter. Something else I sometimes get calls about is that the suprapubic catheter's fallen out and what should be done because it fell out hours ago. Well, you've always got the urethra usually. So if you can get a urethral catheter, the safest thing to do is just place a urethral catheter in, and then that patient can come back later for their SPC to be reinserted. And again, I'd suggest that video. I'm going to speed up a little bit because I'm just cognizant of time, but I just wanted to show you this picture because this is something that you might well come across and it looks really alarming. So this is traumatic catheter cleavage. So what happens is that in gentlemen with long-term urethral catheters, these catheters cause urethral erosion. So you can see that around the catheter, you've got this sort of erosion. And over the phone, people have described this to me as an ulcer or the penis splitting apart. This is something that happens over a long time. It's not an acute thing. The treatment for this is really a suprapubic catheter. So suprapubic catheters don't cause catheter cleavage. So normally we recommend that patients that need long-term urethral or long-term catheters have an SPC as opposed to urethral catheters to prevent this from happening. Right, okay. Urinary retention. So when I was in medical school, I probably as an F1, I definitely don't think I knew that there were 2 types of retention, but there are. So there is acute retention and chronic retention. And chronic retention, there are two types of chronic retention as well, but I think we're going to keep it super simple because you definitely don't need to know about that. So there are differences between the two. And the first difference is the presence or absence of pain. So people that present with acute retention are in pain. They're in pain because they cannot empty their bladders. People with chronic retention, however, don't present in pain. So they are happily walking around with 2 or 3 litres in their bladder, not even knowing this. So these are your men with benign prostatic enlargement. So as the prostate grows, the bladder is obstructed, and as a compensatory mechanism, it distends. So a normal bladder capacity is about 500 mils. So you and I will be able to store about 500 mils in our bladder before we really need to go to the toilet. However, patients with chronic retention often have, as I say, 1.5 litres, 2 litres, 3 litres. The most I've ever seen is 9 litres, and that patient looked pregnant. So that is a clue as to whether you've got acute or chronic retention is whether or not the patient's in pain. Renal impairment. So patients with acute retention will have normal renal function. Patients with chronic retention often have renal impairment, and the reason for that is as your bladder becomes full of urine, you then get backfilling of your ureters with urine, and that goes all the way up to your kidneys. You get hydronephrosis, and that causes kidney impairment. So if you have painless retention in someone that has and an AKI, you're thinking, okay, this is chronic retention. So the presence of hydronephrosis also suggests that someone is a chronic retainer. So if you see bilateral hydronephrosis on an ultrasound or on a CT scan in a man or a woman with a very distended, large volume bladder, you're thinking, again, this is chronic retention. So the other feature you can look at is the residual volume. So the residual volume, what that means is the volume of urine that drains after catheterization. So you place, or on a bladder scan, so you place a catheter, and that immediate volume of urine that is drained, that is your residual volume. So in general, this is a rough rule, patients with acute retention usually have less than 1 litre, so 400, 500, 600, and they're in pain. People with chronic retention often have more than 1 litre in their bladders. The next way of differentiating is post-obstructive diuresis, and we'll talk about this a little bit more, but what happens when in chronic retention, when the kidneys have been obstructed for so long, is that you get a diuresis because you've had excess sodium and fluid retention. So you'll have a transient physiological diuresis, which is completely normal. But if that is prolonged, so if that's something that's happening for a prolonged period of time, that is something that needs treatment, and also marks the patient out for being a chronic retainer as opposed to an acute retainer. So what types of retention should you discharge? So you see your patient in A&E and they've come in with acute retention. So acute retention, absolutely place a catheter in, start your patient on tamsulosin and refer them to the TWOC clinic. However, if the patient has chronic retention, they need to be admitted and under a urology team. So the reason for that is because we need to see whether or not they have post-obstructive diuresis, because the problem with post-obstructive diuresis is that if the patient becomes polyuric and is passing 4 or 5 or 6 litres of urine a day, they eventually can't keep up with that fluid loss, and they become dehydrated very quickly, and that can lead to all sorts of electrolyte abnormalities. So we need to monitor them really closely, and we also need to plan their future management. So if you see someone with chronic retention, they need to come under urology. They need to at least be discussed with a urologist. And then finally, can you TWOC someone with acute retention? The answer is yes. Should you TWOC someone with chronic retention? Never really. So if you TWOC someone with chronic retention, they are going to go back to square one. They're going to start storing a large volume of urine in their bladder. That's going to lead to hydronephrosis, AKI, and they're going to come straight back to hospital. And you can have really dramatic creatinine with these patients. You know, you can have AKIs with creatinines of 1,000, eGFRs of 5, so it can really be very dramatic.
So we have a couple of questions about this. The first one is asking, I'm often asked on call about whether to catheterize patients with reduced urine output, i.e. not dehydrated, and painless urinary retention of reasonably significant volumes, for example, 700 to 800 mils. Should I catheterize?
So for the first point, the patients who have reduced urine output, the answer is yes, because if they're why do they have reduced urine output? So often it's because they're septic. So as part of your sepsis 6, you catheterize them because you want to monitor their fluid output and you want to titrate the amount of fluid you're giving them to how much urine they're producing. So as a rule, you should be passing 50% of your weight per hour. So if you weigh 90 kilograms, a good urine output, a normal urine output should be roughly 45 mils per hour. So if you've got a patient that's passing 10 mils, 20 mils, you need to know that because you can give them a fluid challenge, but you also need to monitor how they respond to that. So yes, a reduced urine output is an indication for catheterization if it's needed for fluid monitoring. The second point was painless retention. So if they've got painless retention with I would say yes, in general, yes, as a rule of thumb. Now, there is a bit of a sort of nuance here because within chronic retention, you have two groups of people. You've got people that retain a lot and have an AKI, or they have renal impairment, and then patients who retain a lot but don't. But I think that if you're having patients with 700, 800 mils in their bladder, I would catheterize them and then definitely refer them to a urologist for further management.
And we also have a question asking, is there a recommendation that acute retention over 1 litre needs to be admitted from A&E?
So I would, so it's unusual to, if they're retaining more than 1 litre, I think I would question whether or not it really was true acute retention. And I think that more than 1 litre, I would certainly admit them at least for a few hours for monitoring of their urine output following catheterization. And in that case, yes, they can be monitored for a few hours. And then if they're diuresing, then that sort of suggests that actually they're probably a chronic retainer and they should come under us. So that's why I use 1 litre as a rule of thumb, because to see an acute retainer of more than 1 litre, I don't think I've ever actually seen someone with acute retention with those volumes. Okay, so always document the residual volume. So when you put a catheter in, always look at how much urine is drained and document that volume. Why? So firstly, because it helps us work out whether the patient has acute or chronic retention. And it also helps us work out how we manage the patient. So people with chronic retention, we will offer a TURP, so transurethral resection of prostate, to get them catheter free. So we basically remove all that excess prostate tissue you saw in that initial picture I showed you, to basically go from a hole that big to a hole that big. And really the residual volume helps us work out how successful, or it can help us work out how successful our TURP is going to be. So if someone is retaining 2 or 3 litres in their bladder, a TURP probably isn't going to get them peeing normally again. So it's not something that you have to interpret, but it is something that you have to document because it helps us work out what we're dealing with. Right, so post-obstructive diuresis. So the definition of post-obstructive diuresis is passing more than 200 mils of urine for more than 2 consecutive hours. So when you catheterize your patient in retention, you say to your nursing staff and you write in the notes that you want hourly urine output documented. And then you come back and you look at the urine output. And if that patient has passed more than 200 mils for 2 consecutive hours, that is the definition of post-obstructive diuresis. So they might have passed 400 mils in the first hour, then 300 mils in the second hour. So they're diuresing and they need to have fluid replacement. So you prescribe fluids for them at 50% of the previous hour's urine output. So that means if they've passed 400 mils in an hour, you replace 200 mils of fluid. And the way to get the nurses to do this is you have your fluid, your drug chart, and you write up your bag of fluid. So saline, 1 litre, and then underneath that, what I normally write is 50% of previous hour's urine output, if passing more than 200 mils for more than 2 consecutive hours, and that is fine. So there's no special form or anything like that. You can literally write that up on the back of your fluid chart, and the nurses will do that. So the difference between phimosis and paraphimosis. So we've already talked about phimosis. You know what that is. That is just a tight foreskin, where you cannot pull that foreskin back over the head of the penis. Paraphimosis is something different. So this is paraphimosis. So this is what happens when you retract the foreskin beyond the glands, but you don't replace it, so you don't pull it back. So the foreskin gets stuck. The foreskin is usually a bit tight, and that's why that happens. So the foreskin gets stuck behind the glands, and then it gets edematous, and it gives you that appearance, which looks fairly alarming, but is quite simple to treat. So how do you treat it? So first of all, try and prevent it from happening in the first place. So when you're catheterizing people, you have to retract the foreskin to do that. So it's really important that once you've finished placing your catheter, you replace the foreskin, so it doesn't happen. But if it does happen, there are 2 treatment options. So you can either get a swab of some gauze and soak it in 50% dextrose, and that's usually available in ITU, and wrap the paraphimosis with that and come back in an hour or so, and you'll find that it's much easier to reduce. Or manual reduction. So this is how you do it. So it's a 2-handed technique. You place 2 of your fingers under the glands, both your thumbs on top of the glands, and you're simultaneously pulling up while pushing the glands down. Now, this does hurt. And I tell patients this is going to hurt for about 5 seconds, but once it's reduced, you're going to feel so much better. So you do have to apply a lot of pressure to do this. So it's not just a, pathetic, weak movement. It's really pulling and pushing at the same time, and that normally works. So if you've tried that, if you've tried to reduce the paraphimosis on the ward and you cannot reduce it, then that is the time to call your urology reg, because what we will do is probably have a go ourselves. But if that doesn't work and it's really, really stuck, the patient needs a dorsal slit. So, but usually manual reduction works quite nicely. Right, so how much time do we have? Okay, renal colic. So stone disease is really, really common, more common in men than women. And the main sort of risk factors are geographical location, climate, season. We always get more stones in the summer, after a heat wave especially. People who don't drink very much, so commonly chefs are big stone formers, office workers who just sitting down all day and not drinking very much. It presents as loin to groin pain, so that's your textbook description, and it is the worst pain ever. People will tell you that women will tell you that it's worse than childbirth, often associated with nausea and dipstick hematuria. So what investigation do you order? So a CT KUB, so KUB stands for kidneys, ureters, bladder, and that is a non-contrast scan. So it's got a very low radiation dose, and it is brilliant for picking up stones. And as you can see on circled in red, that is your stone there. So you've got a stone there in the proximal ureter. So if you're not familiar with looking at CTs, that's your kidney. That's one kidney there on the right. That's your left kidney there. This is your ureter coming into view. These are your hip bones here, pelvis and hip bones there. This is your spine. So you can see there, white is bone or stone, so calcium. So that's that over there. So really important to consider differentials, especially in your elderly patients. A AAA, a ruptured AAA has to be the first differential you consider. Following that, appendicitis, if you've got right-sided pain, diverticulitis, biliary colic, an ectopic pregnancy, really important that your patients, your female patients have had a pregnancy test. I've actually had a patient referred as a renal colic that turned out to have an ectopic pregnancy. So it does happen. So always make sure that you've got your beta HCG. And you can get referred pain as well. So sometimes men come in complaining of testicular pain. Their testicles don't really feel tender on examination. And you sometimes get that pain when you've got a stone right at the distal ureter that's about to pop into the bladder. So that's something to consider as well. So you'll probably do an A&E job at some point in your career, and you'll probably be calling us to refer a stone. So these are the 6 things we need to know about your stone referral. First of all, where is it? Distal, mid ureter or proximal ureter, so top, middle or bottom. We then need to know the size of the stone, because those are those will tell us whether or not you've got a good chance of passing your stone on your own, or whether we need to intervene to get rid of the stone. The next thing we need to know is whether or not the patient has an infection. So one of the sort of true urological emergencies is an infected, obstructed kidney. So if you have a patient with a kidney stone that's got raised inflammatory markers and impaired renal function, then that is a urological emergency. And that is something that we take very seriously, because patients can become incredibly sick with it. So we want to know your white cell count, and it is normal to have a slightly elevated white cell count with stones. So we normally see patients that have a white cell count of sort of 12, 13, 14. So that is not unusual, but that's why the CRP is important as well in telling us whether or not the patient's got a superimposed infection. We want to know the renal function. So it's not uncommon for patients with stones to have a mild AKI. That in itself is not a concern, because their kidney function will go back to normal once the stone has passed. But what is dangerous is if they've got an AKI with infection. So that's the one thing that I really want you guys to take away from this today, is that an obstructed infected kidney is an emergency. The other thing we want to know is whether or not there are nitrites in the urine, because that's a sign of a urinary tract infection, and whether or not they have a temperature. So if you give us those 6 things, we'll be ecstatic, because most of the time we only get 2 or 3.
So we have a question asking, what would be the size cutoff?
Oh, so we're going to talk about that now in my next slide, I think. Okay, not in my next slide, but in a subsequent slide. So first of all, how do you manage these patients? So the first thing is giving these patients good analgesia, because they are in a lot of pain. So your first line for renal colic is PR diclofenac. It's not morphine. Morphine just makes people sick. It doesn't really touch stone pain, and then they just vomit, and then it's a vicious cycle. And some A&Es that I've worked at really, really understand this well, and everyone gets PR diclofenac. But some A&Es are really poor for some reason. poison and all patients get morphine. I'm not quite sure why that is, but first line is diclofenac, and that works really well. And then we need to think about how are we going to manage this stone. So these are the options for managing your stone. So a conservative trial, that means we're going to let the patient try and pass the stone on their own. And the other options are ESWL, that stands for extracorporeal shockwave lithotripsy. So that is using lithotripsy to break up the stone from the outside. And then our other options are, do we need to place a stent or a nephrostomy? And I'll talk about when we need to do that. So someone asked about cutoff. So conservative trial is for patients who have small stones, and you can see here that two factors affect your ability to pass a stone: the size of your stone and the location of the stone. So one of the first questions, one of the first MCQs was, what's your chance of passing less than 5 millimeter distal ureteric stone? And you can see there that it is almost 90%. So if you've got a small, so less than 5 millimeter stone in your lower ureter, you've got a 90% chance of passing that stone on your own. However, if you've got greater than 7 millimeter stone in your proximal or upper ureter, that drops right down to 14%. So the smaller the stone and the more distal it is, the more likely you are to pass the stone. Some medical school textbooks will talk about giving tamsulosin, and that was something that used to be done routinely until this trial called the SUSPEND trial was published some years ago, which showed that there wasn't really a benefit of giving tamsulosin apart from perhaps distal stones that measured greater than 5 millimeters. So that is really the only area in which I suggest giving tamsulosin. For anything else, we don't routinely give it anymore. So going back to the question about when we would opt for conservative trials. So really, if a patient doesn't have an infection, if they've got a normal or a mild AKI, if there's no temperature, they've not got nitrites in their urine, we allow the patients to pass the stones on their own. And you've got to counsel your patient really well. You've got to say to them, it is going to hurt. We're going to send you home with diclofenac to use as required, but expect that this will hurt. And at Brighton, we have a great way of managing these patients. We send them home with all of this advice, and we follow them up in a virtual stone clinic. So these patients that are managed conservatively all get a CT, a repeat CT KUB in about 4 weeks' time. And then those stones those cases are reviewed virtually by Mr. Symes, one of our stone consultants. He looks at the imaging, and if the stone is passed, then he'll just write to the patient and say, you've passed your stone, you don't need any further follow-up with us. But if that stone is still there, we can then arrange further treatment for them. Now, it's really important that if you're going to send your patient home with a conservative trial, you need to safety net them if you're seeing them in A&E. So you tell them, look, if you get a temperature, if you get signs of infection, so feeling shaky, shivery, hot, cold, or if your pain is not responding to painkillers, then you need to come back to A&E straight away. And that's an indication to be admitted by the urologists. So when do we need to put in a stent or a nephrostomy? And I'm going to show you pictures of both in a second. So the main indication is an infected, obstructed kidney. So if you've got a stone there that is causing obstruction and you've got superimposed infection, you've got to decompress and deobstruct that system rapidly. And you do that with either a stent or a nephrostomy. So that is essentially a drainage tube which bypasses the stone. So it's important to note that you're not treating the stone at that point in time. You're simply bypassing the stone. You're allowing all of that infected urine to drain, and you leave the stent or nephrostomy in. You allow the infection to settle down, and then you bring the patient back at a later date when all that infection is settled, and you then treat the stone. So definitive management comes later. The emergency management, which is to treat the infection and treat the obstruction is to decompress the kidney. Other indications are if you've got pain that's not responding to analgesia, or you've got really bad nausea, vomiting, a single kidney, or if you've got two kidneys and both kidneys are obstructed. So these are what stents look like. They are thin plastic tubes. One end sits in the kidney, one end sits in the bladder, and they just bypass the stone. Now, something that you will commonly see in A&E is patients coming in once they've had stents and they say, oh, I've got really bad pain, I've got blood in my urine, I've got, I think I've got a urinary tract infection, or I'm going to pee all the time. So those fall under the umbrella of stent symptoms. So stents, I tell patients, you're not designed to have plastic tubes in your body, and they do cause symptoms. So if you have a stent, you will have blood in your urine. You might not, but if you do, that is completely normal. It's caused by that little curved pigtailed end rubbing against the lining of the bladder and causing local irritation and trauma. So blood in the urine when you have a stent is normal. It's not an indication for admission. It's not an indication that things are going wrong. It's completely normal. The other thing that patients complain of is needing to pee all the time. They get a sense of urgency and frequency. And again, that's because you've got that distal pigtail rubbing against the bladder, and it's sort of sending signals to the brain saying, oh, I'm full, I need to pee. But when they rush to the toilet, not very much comes out. And again, that's completely normal. It's not a sign of a urinary tract infection. Sometimes patients complain that when they pee, they get a pain up in their kidney. Now that's caused by reflux of urine up into the kidney. And you just tell patients, so stent symptoms can be really severe. And the problem is that there is a spectrum. So you've got patients who don't know they have stents. They completely forget that they have them. And then you get patients who tolerate them really, really poorly. And you have no way of knowing preoperatively where on that spectrum your patient is going to lie. So a lot of it is sort of educating your patient and telling them what to expect. But if your patient is really struggling with stent symptoms, then you can prescribe them either 5 milligrams of solifenacin once daily or tamsulosin to help. But you just tell them as well, look, the symptoms will go once the stents are out. So just be patient if you can, and those symptoms will go away. So this is the alternative to a stent, so a nephrostomy. So we normally use nephrostomies in really sick patients who, for example, might not be fit to have general anaesthetic because they're so unwell. And nephrostomies are put in by the interventional radiologist, not by us, and they're put in under a local anaesthetic. But the principle is the same. You're deobstructing the kidney. So that covers the emergency management of stone. So you might have placed your stent or your nephrostomy, but you're still left with the stone there and you need to treat the stone. So you've got two options. And broadly speaking, a ureteroscopy is one of those, and that's really for the smaller stones. So that is a camera which is placed through the urethra, through the bladder, up into the kidney. We find the stone, and the picture here shows what that looks like, and then we use a little laser fiber to break up the stone into lots of little fragments, and then those fragments pass, or we use a little basket to basket the stone out. So that's good for the smaller stones. But if you've got the big stones, the staghorn stones, so stones that are sort of bigger than 2 centimeters, we do what's called a PCNL, or a percutaneous nephrolithotomy. So that is where we make a puncture onto the kidney, so the patient lies on the operating table on their front, so prone, and then we puncture onto the kidney, we dilate that tract, we get onto the stone, and we use a little drill or laser to break that stone up, and it's really satisfying surgery. So I know I'm over time, but if it's okay with you guys, I'll quickly go through the acute scrotum and then I can take questions. So the acute scrotum, your main differentials are either testicular torsion and epidermoorchitis. These are sort of some features to help in the history that might help differentiate between the two, but really what is going to help you as well is the age of the patient. So there is a bimodal distribution. So you get an initial peak in torsions in the first year of life, and then you get a second surge in adolescence. So if I get a phone call about a 50-year-old man with suspected torsion, I know it's not a torsion. I know for a fact it's not a torsion. That's not to say it's impossible. It can happen, but almost, I would say 9.9 times out of 10, it will be an epididymoorchitis, because torsion in that age group is not common, but epididymoorchitis is. And the reason why you get epididymoorchitis in older men, it's not sexually transmitted infections, it's bladder outflow obstruction. So their prostates get bigger, they don't empty their bladders well. That residual urine that is sitting in the bladder acts as a really good focus for infection, and that then tracks down to the testicles. This is why torsions are important, because if you don't fix them in time, if you don't explore them in time, you get a dead testicle, which has to be removed. So there is a 4 or 6 hour window to salvage a testicle. So if you suspect a torsion, you just need to speak to a urologist immediately. And if they are young, that needs to be a really urgent discussion. So if it is a torsion, what we do is we fix both sides. So we do a scrotal exploration, untwist the testicle, hopefully it pinks up, and if the testicle pinks up, that means it's salvageable, and we'll fix both sides. So what we do is place sutures through the testicle into the wall of the scrotum to stop it from twisting again. And we know that if you've had a torsion on one side, your risk of having it on the contralateral side is higher. So that is why we fix both sides. If the testicle is dead, you remove the dead testicle and then you fix the contralateral side. One of the differential could be a torted hydatid of Morgani. So that is a appendage that sits on the top of the testicle, and it's associated with the blue dot sign. Now, if you see this blue dot sign, and I have to say, I have only seen it once, you can be really confident that this is not a testicular torsion, and you can manage that conservatively. But often you don't get this blue dot, and so we do end up exploring a lot of these patients, and they tend to be children actually rather than adults. And I think this is the last thing we're going to cover. So Fournier's gangrene, which is another urological emergency. So necrotizing fasciitis of the perineal, gluteal and perianal region. It has a very high mortality. So historically, we would quote it as 50% mortality. Now it's probably between 10 to 20%. So you think Fournier's gangrene if you hear the words diabetic, long-term catheter, elderly, nursing home. Those buzzwords should make you think of a Fournier's gangrene, and that's what it looks like. You get these areas of desquamation and then necrotic tissue. So it's really important when you examine these patients that you not only look at the scrotum itself, that you lift the scrotum up and actually look at the perineal area and the perianal area as well. Because that might be where the infection has started from. So so etiology can either be urogenital or anorectal or from the skin. And you can read all of these different causes, but it's a clinical diagnosis. So in terms of, is there a role for imaging? Some people get CTs, but really your imaging should not delay how you manage the patient. And if you suspect that someone has Fournier's, they need to go to theatre as soon as possible, because this is an infection that spreads rapidly. So I've done debridements where I can see the Fournier's spreading in front of me. That's how quickly it happens. They get sick very quickly and they're really sick. So you've got to manage them quickly. So it's a polymicrobial infection. So you get gram-negative, positive and anaerobic bacteria, which means that when you cover them with antibiotics, you've got to target all of those. So it's triple therapy, and you manage these patients in conjunction with your HTU or ITU colleagues, because as I say, they get very sick. So you aggressively resuscitate them, give them IV fluid, start them on triple therapy IV antibiotics according to your local hospital protocol, and then you need to take them to theatre urgently for debridement of all of that necrotic tissue. Sometimes you need to involve the general surgeons who will do a defunctioning colostomy. Sometimes we put in suprapubic catheters as well. But the principles are sort of your sepsis 6 management and then surgical debridement. And then we take the patients back to theatre on average about 2 more times after our initial debridement to make sure that we've definitely gotten rid of everything that's necrotic, all the infection. And at your first debridement, you have to be really radical. You take more tissue if in doubt, because that is, if you don't, your patients don't do well. So you manage the fourniers, you do your debridement, and then once that is all healed, you get granulation tissue, then you can involve the plastic surgeons who normally cover the defect with split skin grafts. Right, so we're done. So well done, everyone. So now we're going to the questions, and there's a chance for you to do them again. So we'll do this question first. Okay, so the answer to that, if you didn't see it just now, is bilateral hydronephrosis. Okay, the teachers just told me I need to talk through the questions. So post-obstructive diuresis is defined as, I'll give you, so more than 300 mils for 3 consecutive hours, more than 150 mils for 2 consecutive hours, more than 300 mils for 2 consecutive hours, more than 200 mils for 2 consecutive hours, or more than 200 mils for 3 consecutive hours. And hopefully you chose D. So I think that's easy to remember, 200 mils for 2 consecutive hours. Okay, question 4. Patients with post-obstructive diuresis should be given fluid replacement at what percentage of the previous hour's urine output? 100%, 75%, 50%, 25%, or 10%? Hopefully you've gone for 50%. And then lastly, I'm sure all of you will get this right. That is definitely not penile cancer. It's also not balanitis. It's definitely not phimosis, which means it is paraphimosis. Right, so that's what we covered. Well done if you made it to the end. And I think now we're going to do some questions.
Yeah, that was great. Thank you, Niyati. We've got a lot of questions, so I think for the purposes of time, yeah, I think for the purposes of time, we'll probably do like the first 2 or 3, if that's okay. So the first one we're going to talk about is how soon after catheterizing should we TWOC?
Okay, so for patients with acute retention, you start them on tamsulosin. You like to give them a week on their tamsulosin to help that work and help them pass their TWOC. So I normally say a minimum of a week, but what you would normally do is refer them to the TWOC clinic. But obviously, if you've put in a catheter for fluid monitoring purposes, you just remove it when that catheter is no longer needed because the patient's better. So it depends what your indication is for. But importantly, you never TWOC a patient with chronic retention.
Great. Another question is asking, if a patient has their testicles fixed, can you exclude torsion in the future?
So if a patient has their testicles fixed and they then come into hospital with testicular pain, it is extremely unlikely that they've got torsion. And often we fix them, well, practice differs around the country, but sort of your gold standard or textbook way of fixing them is using Prolene, so a non-absorbable suture. And often in patients that have had previous fixations, you can feel the sutures, and that is sometimes reassuring. It's honestly, I would say, essentially, if they have had a previous fixation, they don't have a torsion. There are some, maybe a small subset of patients who you're just not sure, or there's something not quite right, and we might decide to explore them, but it's always a really difficult exploration because, of course, they're scarred and the tissue planes are distorted. So the answer is, you almost certainly it's not a new torsion.
Great. And I think our last one, it's a little bit long, but I thought it might be quite relevant. So in a patient that has had a catheter inserted due to acute retention secondary to BPH, and they're awaiting a TURP, is there a risk that during the waiting time, particularly during the COVID time, is there a risk of reduction in bladder tone, making future TWOCs less likely to be successful? And if so, what can be done to overcome this?
Yes, there is a risk, but not over a few months. So that risk, I think, is over a few years. But in someone with acute retention, you've started them on tamsulosin, or you should have started them on tamsulosin. So actually, you should improve their bladder emptying while they're waiting their TURP.
Great. And our last one, actually, because one just cropped up. How soon are we expected to TWOC patients with a three-way catheter?
So you TWOC a patient with a three-way catheter once their hematuria has resolved and you're confident it's definitely resolved. So you're happy that it's not going to restart, they're not going to need irrigation any longer, and it's then safe to TWOC them.
Okay, great. I think, sorry guys, people are still asking questions, but
I'm happy to answer if people want to ask them.
Okay, I think we'll ask a couple more. So what is a normal post-MIC volume?
So strictly speaking, you should empty completely. So you and I, when we pee, we should have 0 mils left behind in our bladder. But obviously, people might have 10, 20. In terms of when it starts becoming a problem is when you're leaving behind, I'd say, sort of, this is an arbitrary figure really, because it's not so much the number, it's are you getting complications with it. But if you're constantly leaving behind 100 mils, 200, 300, or anything north of that, then yeah, that's starting to become problematic.
Great. And we have one question regarding the technique for reducing a paraphimosis. And they're asking, which technique do you normally recommend doing first, manual reduction or dextrose gauze?
So manual reduction, the reason for that is because you'll ask people to get 50% dextrose and no one will know where it's kept. It'll be at the back of a cupboard in ITU somewhere, and it's just a pain in the neck to obtain. So I prefer manual reduction because you can reduce them really quickly without needing any equipment at all.
Okay. Another question is asking, would you start finasteride in a BPH patient who's been catheterized for acute retention and they're awaiting a TURP?
Yes, I would. And the reason for that is not so much for the patient, but for the surgeon. So finasteride reduces the vascularity of the prostate. So when it comes to doing your TURP, it makes the TURP easier to do because there's less bleeding. So at TURP, you often have prostates which just bleed the minute you touch them. And so finasteride just helps reduce that sort of oozing and bleeding. Not always, but it's not a bad idea to put them on it. Got to counsel them about the risk of erectile dysfunction though, and impotence.
Okay, that's great. I think that's all the questions for now.
Great.
let's move on. So do we have any more slides?
I think that's it.
Great. All right. Well, in that case, thank you so much for our webinar, for attending our webinar. We do have another webinar coming up next week, and that will be on ENT by Mr. Robert Grounds. Are you sure there's not a slide at the end of the PowerPoint, Niyati, actually giving?
Oh, maybe there is. Sorry. There we go. Sorry, apologies. There is a slide.
So
yes.
Go on then.
Yes.
Okay, so before we go on to next week's webinar then, please fill in our post-course questionnaire. That's going to pop up when you finish the Zoom webinar. And by filling it in, you'll receive your certificate of participation, and it will really help us out in knowing like what we can do to improve our future webinars or the things we've done right. And there's a QR code in that slide to join our mailing list. And then our final slide is our next webinar. So the QR code you can see on the screen now will lead you to the registration page for next Wednesday's webinar, which will be by Mr. Robert Grounds, who is a senior registrar in ENT in the KSS Deanery, and will be covering emergency ENT presentations, ENT referrals, and postoperative complications in ENT. So I'll leave that on the screen for like half a minute or so in case you want to register now. But whilst you're doing that, I want to say a big thank you to Niyati. That was fantastic, and thank you for staying a little bit over to answer the questions, because I think they're really, really interesting and useful. So I think, yeah, you've done
it's a pleasure. Thanks for having me.
Great. So without any other questions coming up, I think that's going to be the end of our webinar. So hopefully we'll see you next week for ENT.